Okay, that's started. The recording has now started.
Perfect. So, hello everyone. My name's Matthew, and I work alongside Josh as part of the education and outreach team at Jnetics. We really appreciate you joining us for the latest event in our flagship lecture series. We'd like to extend a warm welcome to anyone joining us for the first time, and to those returning, we're very grateful for your continued support. Jnetics are a charity who exists to educate on and reduce instances of genetic disorders which are more frequent within the Jewish community and the general population. We do this through our free and subsidized carrier screening program, funded entirely by the generous donations supported by various educational and fundraising events. For tonight's lecture, we will be taking a deep dive into Usher Syndrome, one of the conditions on our screening panel. We will first hear from Emma Boswell, a powerful patient advocate who manages the Usher service for Deafblind UK, chairs the DBI Usher network, and has co-authored a newly published book, Usher Syndrome: About Us, By Us. We will also be joined by Dr. Randa Li, who currently works as a clinical trials research fellow in Moorfields Eye Hospital, investigating the use of an experimental RNA therapy designed to slow or stop vision loss in people with Usher syndrome type 2A. Once again, I thank everyone for joining us tonight, and without further ado, I'll hand it over to Emma to begin her presentation.
Lovely. Hello, everybody. Thank you, Matthew, for inviting me to be here tonight. So it's lovely to join you all. So I will be here to talk about my own personal experience and also a bit about my own work. So hopefully you'll have a nice variety tonight to take in. I may be looking over to this side because I have my interpreter on a very large screen, which is easy for me to see. So I am now trying to look forwards if I can so that you can see me looking at you because my laptop screen is quite small, but that's just a bit about part of my access for the vision that I have. I just wanted to check in, is everybody okay and can see me okay and hear everything okay? Quick communication check.
Can't see you, I can hear you.
Diana says she can hear but not see. If people go to Employability Deafblind UK, if you scroll among the meeting attendees, and if you pin Emma if you click on the three dots in the top right, and then you can press. Oh, hang on a minute. I spotlight. Perfect. I've done it for everyone. Okay, great. So, if anyone can't see Emma now, please say. Emma should be in the main screen for everyone right now. Okay.
I think Emma just had to repin, sorry.
Okay, perfect.
Oh, Emma's saying now my interpreter has disappeared. Oh, this is because of the spotlight. Because you've spotlighted Emma for everybody, Emma can't now see me as the interpreter.
Okay.
Do you need to check anything?
Okay, I've removed the spotlight. So now everyone should individually go on to the person titled Employability Deafblind UK. Press the three dots and then pin.
Okay, it's just Emma's now just saying I can't see my interpreter at all now, and I may just go ahead without. But it may be. Okay, Emma, so sorry about this.
Can you guys see each other now?
Oh, Emma's just had some help, but I think something's just popped up again.
Okay. Well, if anyone wants Emma to be at the front of their screen, they should go alongside the top of the screen where you can see all the attendees. Press the three dots in the top right corner, and then press pin, and that will make Emma the front of your screen. I can't do it for everyone because then Emma won't be able to see her interpreter. So I'm going to let everyone do it themselves. So you hover it above her profile, press the three dots in the top right corner, and then pin. Can I just confirm, Emma, can you see Rachel?
Yes, now I can see Rachel.
Perfect.
I'm so
Okay.
sorry, but
No,
yes,
no
I
worries
have
at
to
all.
look to just make sure that I've got
Yeah.
my interpreter there and she's able to keep up and translate the information. So I am sorry. I had to sort
No,
of,
no worries at all.
I think this is the IT issues. They always happen and we
Yes.
just have to move along with them. That's
No,
fine.
no worries at all. No worries at all. We haven't hasn't taken too much time. So yes, we should get started then. No one wants to hear from me. Let's get started.
Absolutely. No worries at all. So I will go through a bit about my life experience with Usher, and growing up with Usher, going through education, my own journey with Usher syndrome, and everything that comes with that. I will also talk about how I started to work with people with Usher syndrome. And I would talk about the current work that I do and the people that I work with and what kind of support I offer now. So I have Usher. I grew up with a very sort of regular lifestyle. I grew up as with a deaf identity, and I wore a very old-fashioned hearing aid that sort of had to sit round my neck and had the box sitting on my chest. I had a brother and sister, a brother who was hearing and a sister who also had Usher. I did also have stepbrothers and stepsisters as well. But my life was fantastic growing up, living on the farm, doing lots of different activities that children normally do, playing in the farm, running around, riding on a bike, going swimming, lots of different sports, very much like any other child would. As far as my education goes, I went to a boarding school, which I attended from the age of 2, which I know some people think, goodness, that's such a young age. I mean, I don't really have the memories from those very early days, but I know that I had a wonderful time at boarding school. There were fantastic staff and teachers around, and my sister attended the same school. It was a very lovely setup because it was a boarding school for deaf children. So I think as I grew up, I never knew or worried about my eyes. I wasn't aware of my Usher syndrome. And I had things such as speech therapy. My mum was very insistent on helping me with my speech. And we're talking about the 70s then. So sign language really wasn't very well promoted at that time, wasn't really in use. It was when I started secondary school, which was also a boarding school, very sort of different from my younger education because that was a very small school, very tight-knit. And also, I wasn't experiencing any issues in my vision in that time. So I wasn't really feeling any effects of having Usher. It was when I began secondary school that I really started to notice more difficulties. So for one, I was now struggling to lip read the teachers during class. I wasn't able to take things in. I would start to daydream after about 5 minutes of trying to lip read, as this was still an orally educated school. I just couldn't keep that concentration on the teacher. And obviously, as I say, the education system was very different back then. There wasn't the SEND type setup for special educational needs that there is now. So I think in my time, it just wasn't looked at. There wasn't anything additional that was put in place. I still took part in lots of different sports when I was at school, so I still wasn't having as many issues. Netball was a favourite of mine as well, but I was noticed that I was always picked last. I was always picked last, and I think this now comes into play of the fact that I was struggling with my vision. I was always missing the ball, and people didn't want to pick me for their team. For some of the other sports like swimming and running, obviously I wasn't so much affected. I used to find that the winter months also start to become very difficult, and this is because it gets darker early. So this was the real start of me struggling to find my way from the manor house into the main hall for sort of the canteen. And I struggled to navigate outside when it was so dark. I could not see at night time. I found that I was starting to navigate by touching the walls and feeling the bricks, and that would help me to know whereabouts I was and how many steps I would have left before I turned the corner, before I got to the next part of the corridor. And I really had a strong support network from my friends that we would often walk together. If there was a fire alarm, which did actually happen once when we were sleeping, I wasn't able to get out without the help from my friends. And I think that was the start of me noticing issues with my eyes. I was struggling with night blindness. I also had always noticed that I had poor balance. So I couldn't walk straight. I was often quite wobbly and would go wayward side to side down the corridors. So as I started to get older, or I should say, while I was younger, I didn't have too many troubles with vision and balance. As I did get older and older through secondary, and my vision got worse, the way I noticed this was through losing that balance and losing losing that sort of proprioception. When I left school, I actually went backpacking and joined Operation Rayleigh through the Himalayas. There were about 150 volunteers in the group that were all split into various smaller groups to do the project work. And we were together climbing the mountain. So we had support mechanism within our own groups. And I think it was really part of that got me through it. Because of the issues that I'd faced more and more as I got older, and because of the balance issues, it would have been impossible to do it on my own. We were also staying on a very small island, and things were dark. We often had to use a torch to see things. So there was this constant checking in with each other to make sure that everything was okay. Part of that project, I also took part in scuba diving activity, and I found that extremely difficult. Again, this is where my poor balance came into play. My vision loss was getting progressive, although I wasn't too aware of it. And I was struggling to navigate and struggling to take part in the scuba diving activities. I was struggling to keep myself upright and to take part in the same way that everybody else was. When I got back home from this expedition, it was actually the scuba diving instructor that said, could you actually let me know the name of your disability? Because I'd like to include this within the article that I'm writing for the British Association of Scuba Diving, because of the extra support he had to provide me throughout the trip. And I thought, well, I'm deaf. My disability is that I'm deaf, but it made me question this. And I then spoke to my mum, and she said, Emma, you have Usher syndrome. And my reaction to that was to laugh. I laughed because I think I'd heard of this term before. I knew of Usher syndrome. And I think I always knew that there was these issues. I'd faced a lot of challenges. I'd always sort of grew up quite sort of normal childhood, much as anybody else would. But I knew there were issues that I was facing. And I think having that sort of diagnosis given to me, it hit home that that's what it was. It was a good opportunity because it helped myself, my mum, my sister, and my brother to sit down together and really talk about it, which was nice to get it all out in the open and to see that myself and my sister had Usher. But I still continued to do things. I still learned to drive. I did many other things that other people would do going into their teens and early 20s. It was an appointment at Moorfields Eye Hospital that really had to take away that opportunity to drive because my peripheral vision was becoming too poor to be able to drive. And I think that was the real sort of grieving moment for me with my vision loss, more so than receiving my initial diagnosis from my mum. I think that was a real loss of independence. At that time, I lived in the middle of the countryside. Things were going to be difficult for me to access if I couldn't drive. And this is where I then moved more into the city so that I could access transport. It was a real moment of grievance. I know that many other people with Usher find that kind of emotional response to their actual diagnosis. And I think it's important to remember that everybody is different in this. I have my sister Claire who also have Usher, which means that's a fantastic support network for me. And other people often have support networks of their own, be it with friends or with family. But everybody does experience these things the same. As part of my continuing education, I went to university and completed my degree. I didn't actually have an interpreter with me like I have Rachel here today. I did have a note taker. I didn't use BSL. I wasn't using sign language. That's something I've developed later over the years because, as I initially said, I was brought up orally and had to lip read. But as my vision deteriorated, I had to moderate to a different way to communicate. And this in turn led me to learn BSL, which has now become a more tactile form of communication. So I'm sometimes using social haptic communication, which is tactile, and I now sign in a much smaller space, which is visual frame signing. And I feel that this in turn will have to be adapted again as I start to use more hands-on BSL as my vision perhaps deteriorates further. I think it's important to note that there are so many different ways to communicate, and people with Usher communicate in all kinds of different ways. And for me, right now, that's BSL. That's my preference. This leads me on to access to information, because when I was much younger, I was able to read well. I could access the written word quite easily. I would say perhaps 3 or 4 years ago, I lost my reading vision. And this was a real challenge because that lost my access to information that I once had. It was another sort of point of grief within my Usher journey because it affects your everyday life if you cannot read the information in front of you. I know that some people with Usher can continue to read for many, many years. They may not lose that. Other people may be able to cope with larger prints, different font sizes. Others may use Braille in order to access the written word as well. So again, it really does vary. In terms of employment, I actually started off as working in interior design in quite a well-known high street shop. There was an incident one day where I wasn't able to see the coffee table and I tripped completely over the coffee table and had quite an incident, which then had to be looked at in terms of risk assessment. And we had to look at the kind of services and support that I might need and how things might need to be adjusted for me in the workplace. At this time, I loved doing things to do with design, but it didn't feel completely fulfilling. I realized that I did want to work more with people. I enjoyed being with people. And after I had joined a mentoring project, actually, that I was volunteering with at the time, I then decided that I wanted to continue to work with people. And I changed jobs and started working for the Usher service, which I've been with for the last 20 years. I support people with Usher to help with living well, with information, advice, support. We have a Zoom Usher chat room that people with Usher can join once a month, which is great for socializing and information. For example, we had the Zoom Usher chat room running this morning, and we had one man with Usher who was a musician and came to present to the group about how music can be accessed for deafblind people, those with Usher, to feel the music, to feel the vibrations, which was a really interesting workshop and of real value. We also talk about things to do with the people that contact us, supporting them in terms of the point of diagnosis. It may be for support with their housing. It may be everyday life and accessibility. It could be employment. But this is where we have ways to contact Deafblind UK. So we have the new Usher helpline that has been recently launched, which is available for anybody with Usher, their friends, their family, and professionals such as medical professionals, social work, or other that can contact us within our opening times each day from 10 till 1 and speak to somebody on the helpline to get further advice and signposting. That's really our first point of contact. Within a journey of somebody with Usher, there are many different points, milestones, as I've indicated through my own life story. As your vision deteriorates, as things become blurrier, things become difficult to see, you can't lip read anymore, you can't communicate in the same way that you did, it can be more difficult to gain access to the information that you need. It can be difficult to feel independent and empowered. And that's going to depend on what kind of support somebody needs at each of those life stages. It's important to note that people often need time to come to terms with things and may get in contact for different things at different points in their Usher journey. We have a wellbeing service at Deafblind UK, as well as a befriending service. We have an employment team as well as having the Usher service and our research and education department as well, which means we offer a real range of services for all different kinds of people at different points in their journey. People are able to join Deafblind UK and become members so they can access more information and advice and join our newsletter and such things. And we also are focusing on more rehabilitation to help support confidence and empowerment for those with Usher, which is something that we're still developing. I think it's important also to note that we don't often support people continuously. It's something that people dip in and out of as and when they hit certain milestones through their journey, and they'll come back again and again for different support at different times, and we're always here for them. I want to stress that it's important that people can keep their independence with the right support in place, of course. It's important to keep going with life, to keep moving forwards, and to keep as much independence as possible. So if there are any needs that anybody has or wants to know anything more about Usher, please do get in contact with Deafblind UK, and we're always here. Thank you very much. I think that's it from me.
Thank you so much, Emma. I'm sure everyone watching took so much from that. There's so much value in what you're talking about and the support you offer to people with Usher syndrome, and sharing your own story as well was incredibly powerful to allow people to relate to the condition. And now to kind of give like a 360 view of Usher syndrome, we've heard the patient perspective. We're now going to hear from the perspective of a scientist, a researcher, looking into doing the work to try ensure that the outcome is better for people diagnosed with Usher syndrome in the future. So we're joined by Dr. Randa Li, and she's going to present a short presentation on some of her work, some of the work she is doing to improve the outlook for people with the condition. So without further ado, I'll pass it over to Randa.
Thank you. Thank you, Matt. Would you mind just sharing the PDF? It's because otherwise it might take me a while to upload mine. Yeah.
Yes, no worries. I'm just doing that now.
Can everyone hear me whilst Matt is loading it up for me?
Yeah.
Thank you.
Yep, I can hear perfectly.
Can everyone see the presentation now? It should be sharing.
I can see it has started screen sharing, but it hasn't shown up yet.
Okay. Okay, it says it's loading right now. Uh, Apologies for the delay. Should be working now.
Okay.
Can everyone see it now?
Not yet.
No,
Should I try? Yes.
just got the text saying that you've shared your screen, double click to enter full screen.
It's being very slow to respond.
Oops.
Matthew, do you want to send it to me and we'll try from mine?
Yeah, it's just stuff is loading. I'll try to do that now. Oh, nothing. Apologies for this, everyone.
Okay, in the meantime, Matthew, if you could unshare your screen, and Dr. Lee, maybe if you could start by introducing yourself and making a start, and then we'll work on the
Yeah, no
presentation
problem
in the
at all.
meantime.
Yeah, that's what I was thinking as well. No problem. Okay. Hi, everyone. Dr. Randa Li, and I'm working at Moorfields at the moment and a clinical research fellow. And today I would like to share with you from a clinical perspective on Usher syndrome. So, how do I come across patients in my context? Usually they're referred from the GP to Maria or from another healthcare system. And then usually patients have a history of a family member having ushers, or they could present with a history of sensory neural hearing loss or balance issues. And quite commonly in our clinical setting, patients developing night blindness, issues with walking around in the dark, and also bumping into things, and what we call nyctalopia, night blindness. And sometimes the patients come to us after they've had genetic testing, they've had familial variant testing or segregation testing because a family member has had it. And last but not least, often patients are at their routine optician's check and they present with some abnormal findings. And this will include such things as abnormal scans, abnormal visual field, and so on. So I was going to present to you some, I'll go on to some without the pictures. So as you all know, what we see on the back of the eye is, firstly, we see the triad, the classic triad. Oh, I see my
There we
slide.
go.
This is me. Yes, thank you, Matt. Yeah.
Just say when to move slides.
Yeah. So just introducing myself, I did my medical school in Edinburgh, I studied a master in public health. I did a master in surgery in Edinburgh. I did my ophthalmologist training in Hong Kong, but I came back to the UK during COVID to look after my daughters. Next slide. So I've mentioned all this. Next one. So here is a normal picture on the left side. Usually you have a nice pink picture of the back of the eye, and we see the optic disc and we see vessels coming out of it, the red vessels coming out, and then the fovea right at the center where our most important vision is. In retinitis pigmentosa, on the right of the screen, we see that the disc has become pale. What we call waxy disc pallor is quite classic. And then we see narrowing of the blood vessels, and we see some macular changes, which I'll tell you about later on. Next slide, please. So these are the classic triad I've mentioned. Next slide. So I'm sure some of you have had tests at the opticians, and this is the machine that looks like a big eye, silver or white. But what it does is a ultra wide field, and it takes an image of the back of the eye. And the ultra wide field means that we can see into the periphery of the eye quite well. So we love this, and it's quite an advance. It means we see quite to the periphery. And typically in retinitis pigmentosa, if you compare with the left normal eye, the disc pallor is not so obvious, but usually there is some disc pallor. And also there is in the pigmentation, there's in the mid-peripheral. And then also there is some, as you can see, the vessels are not actually well seen. So that's because they've been attenuated. Next one. And as you can see here, on the normal, on the left side, this is what we call the blue autofluorescence. And it's kind of a highlighting areas of retina, which is unhealthy and abnormal. And if you can see on the right, you can see a hyperfluorescent ring, the bright white ring. This is where there is degenerating or unhealthy retina, the threshold between normal and abnormal retina. Next one. So I was asked to tell you about what I do at Moorfields. I spend most of my time at the clinical research facility. I'm currently recruiting for the LUNA trial, and this LUNA trial looks at the treatment with intravitreal ertifersen, which is a treatment we're looking at into slowing down or stopping the progression of USH2A related retinitis pigmentosa associated with exon 13 variants. So what do I do? At the beginning, I look at the Moorfields database. I look for specific mutations and specific gene, the USH2A exon 13 variants. And then I speak with patients. I let them know there's a trial, and then I tell them about the eligibility screening, and I ask them questions about inclusion criteria and exclusion criteria. And then I bring them in for a look at their old images, I look at their vision, and then I have a good idea whether they are potentially eligible, and I bring them in for screening and for assessments. And once I've done these assessments, I confirm with reviewing the test, and then once they are confirmed to be eligible, they are invited to the study. We randomize them into controls and treatment groups. And then once they're recruited and they've had treatment, we monitor them and we support them throughout the journey. Next. And I also, on Fridays, I attend Maria's adult and pediatric ocular genetics clinic. Here we see patients, we review patients with ushers. They may come for genetic testing, or they might have had genetic testing and they have results to be delivered and to be explained to. And we do this in the presence of our genetic counselors to give genetic counseling, and also we give specific updates on the research related to their specific condition. And if appropriate, we give them dietary and lifestyle advice, and we signpost them to resources. Next, please. And in children, we try to make it slightly different, like a child-friendly environment, a play area with play specialists, and we use a supportive multidisciplinary team approach with our genetic counselors, speaking with parents, optometrists, supporting their vision and vision demands, orthoptists, pediatricians, looking at them systemically, and we give them the family support and with the school support that they need. And I think it's already a difficult situation, and I think all the support helps the child, and it also helps the parent to understand and to accept the prognosis and to ask questions. And also, I feel it is done under one roof. We try to do under one setting so that the patient and the child doesn't have to go to many places at the same time. Next, please. So this is the part Emma missed at the patient information day. So I'm going to run this again, especially for her, but in a brief form. And also, I think it also helps me to cover the part that Matt has also asked me to do, is the clinical research update and what insights I have from the clinical research. Before I do that, I'm just going to explain to you that treatment comes in two forms. Firstly, gene or mutation-specific therapy, such as the RNA therapy in the LUNA trial, which I mentioned earlier. This is for USH2A exon 13 variants. And then we have the gene augmentation therapy, the LUCE for MYO7A. There's another approach, in which is attacking from common disease pathways. We have the antioxidants such as NAC attack, NACuity, gene therapy such as OCU400, optogenetics, rod-derived clone viability factor, and stem cell therapy. Don't worry, I'm going to go slowly in detail. All these jargon words will be explained to you. Okay, so this is LUNA, a form of RNA therapy. Intravitreal ertifersin is the investigational drug. To put it simply, what happens is, if you imagine USH2A as a 72 subunit whole unit, what this drug tries to do effectively, it cuts out the abnormal or subunit number 13, the exon 13. After cutting this subunit number 13, the 71 units subunits that remains forms a more functional, a more normal protein that maintains the health of the photoreceptors. And in doing so, it hopes to slow down progression or even to halt progression of retinitis pigmentosa. Next slide. So this one is in a phase 2B. We're actually close to finishing and achieving the numbers for the phase 2B and for recruitment towards the end of the month. And hopefully after that, we'll just be following patients for 2 years, and we hope to be reporting the outcomes in 2 years' time, 2028, and with interim reports as appropriate. Next, we talk about gene augmentation therapy, and in this case, Avantgarde's subretinal injection of this investigational drug, AAVB081. The simple way to look at this, if you imagine the MYO7A big gene has 7,000 letters, and it's too large for conventional virus to package. So what do? We package it in 2 halves in 2 viruses, and each of them have a tag. And once they enter into cells, these tags helps to bind the 2 halves to produce a full-length messenger RNA and subsequently a full-length protein. Next slide. So this is Avantgarde's for MIO7A. It's in a phase 1/2 testing safety, and then it has finished recruitment January 2026, and they should be coming with reports throughout 2026. So again, this is what we call autofluorescent picture of a patient with retinitis pigmentosa. The back of the retina shows high levels of oxidative stress, shown by the bright hyperautofluorescent ring bang in the middle. And these charged oxygen molecules can cause damage. And this is what they damage. That's how they damage the photoreceptors. Next, please. So this is another pathway we can address the problem, and that's by acting on oxidative stress. NAC, N-acetylcysteine, is actually the antidote to paracetamol overdose. So it is a repurposed drug. It is a high-dose antioxidant. It reduces oxidative damage and increases cone function and survival. It's already in phase 3, but it's a 4-year study. So results will be coming out towards 2029. Interim reports are good, but we won't be seeing the whole report on the safety and efficacy profile until 2029. In view of such good initial outcomes, they actually modified and a more potent, higher bioavailable form of NAC has been reduced and is called NACuity, short name NACA. And this boosts our body's most powerful antioxidant. Next, please. And this one has already reported positive phase 1 or 2 data, and it shows a 50% reduction in photoreceptor loss in patients with Usher syndrome associated retinitis pigmentosa, and they're going to do a confirmatory phase 3, and this is planned for this year, later this year, and the sites are probably starting in Australia. So next, I'm just going to talk about gene therapies such as OCU400, optogenetics, and rod-derived cone viability factor. Next, please. OCUGen is actually active but not recruiting and is a US. And what this one does is the NR2E3 gene is delivered via an AAV vector. NR2E3 is a master regulator. It resets dysfunctional gene networks and reestablishes cellular balance. It's a phase 3 trial and is given as a single subretinal injection. Optogenetics are for more advanced stages of retinitis pigmentosa and where photoreceptors have degenerated already and where traditional gene therapy are not viable. And it aims to make cells responsive to light and to regain some form of navigational vision. Next. And nanoscope appears to be the most advanced and showing promise, and followed by other companies. In future, we hope to see higher and higher resolution and therefore better outcomes. Rod-derived cone viability factor. What is this? This is a protein that is actually secreted by rod photoreceptors to maintain the survival and function of cones. And Sparing Vision's SPVN06 Prodigy, given as a subretinal injection, produces rod-derived cone fiber factors, and they have completed dosing, and we are expecting further reports. So this is just a picture to show you how stem cell therapy works. If you imagine this is the architecture of the back of the eye, our retinal cells, our photoreceptor cells. On the left, you can see very well-structured anatomy showing the cones and photoreceptors or the RPE. But if you look in patients with RP, we see that some of the rosin cones have degenerated. And if I go on to the next slide, if you just remember that slide, I'll go back to it just to remind you. How stem cell therapy work is that we need exact connections to the brain to see. And in RP, our light sensing cells die off, and the stem cells that surround the photoreceptors that remains. And to provide structure, nutrient and protective factors, and to maintain function and slow down degeneration. And that's how stem cells work. And if we go back to the picture previously, if you think about the stem cells, we want the stem cells to reform the structure that we see on the left. So that is the direction we aim with the stem cell therapies. Currently, there are two main ones, J-site and Blue Rock Therapeutics. And with J-site, it's an intravitreal injection of retinal progenitor cells. And the trial's going from August 2025 to September 26th. Then they will follow up this shouldn't be shortened form, it's a follow-up 6 months. And then Blue Rocks Therapeutics have the subretinal injection and is an induced pluripotent stem cell. And again, these are forthcoming, but will be coming later. So we look with keen eyes the results of these. Next one. And lastly, I would like to tell you, which I know a lot of you would be looking for, is like if you're eligible, and how would we recruit you, and how would you know whether you're eligible or not? I would say, number one, please, if you feel you have a genetic condition, get genetic testing done so we know exactly what you have. And after you have it done, be sure you keep these reports nice and safe and in a good place. And when you come for consultations, bring them with you, just in case we don't have copies of them. And I know a lot of you come to consultations and we take history, we ask about family history, whether the condition has happened in other family members. And we always ask, how old are your blah, blah, blah. And it's always just good to know if you do have a potentially hereditary condition to ask about family members or, people you might not come in contact frequently, or just ask your parents if they're still with us, and also family lines if they've had conditions similarly. And please do come for your annual vision checks so that we have updated information about you so that we can check if you're eligible or not. And do come to us so that we have regular, updated retinal imaging that allows us to tell whether you're eligible for trial or not. So in any, and also don't forget to update your addresses, your emails, your mobile numbers, because sometimes because you've changed numbers, we're not able to reach you even though you're eligible. So just remember, one of the basic things we need is your vision. And sometimes we're given vision in different formats. So please provide us with the different formats that is measured. Some people measure in ETDRS, especially in clinical trials, and it comes in a number of letters. Then we have the Snellen, which is 6 over something, and then we have different forms of snelling, but as you can see, these four actually say the same vision, but it's just measured by different units. So when you provide us with information from previous ophthalmologists or GP, or you've had your vision done elsewhere, please be sure that they give you exactly the units of the vision so that we can actually know the vision. And this is a normal ECT showing the retinal layers. And reason why I show this is because it's one of the key measurement outcomes or for inclusion and or exclusion, and also monitoring progression. So if you see, and often if you come to us in a consultation, you'll see something like this. It's like a mountain, and it's actually a very high resolution cross-section cut of the back of your eye. And these are representing layers of the retina. The bright white with the red arrow pointing at is the ellipsoid zone that we always talk about in clinical trials. So if you can just imagine, I'm not expecting you to know all the layers, but you can always just look at from the bottom, and then you see a thin line. The thin line is usually the external limiting membrane, and it's the one that lies beneath it and is called the ellipsoid zone. And these are representations of photoreceptor integrity, and that's why it's so important to us as an endpoint. Next. So these are the numbers, like we can actually get a measuring tape or virtual measuring tape on the OCT scan, and we can measure the width of the photoreceptor, or what we call the ellipsoid zone. And that's why it's quite important. In a normal retina, we wouldn't be able to see the edge, the white thick line. Ideally, it should be out of the frame, so we shouldn't be seeing the edges. But unfortunately, with retinitis pigmentosa, some of the photoreceptor loss with time means that the ellipsoid zone width becomes shortened. Next. And some of you may know that some of the treatable or conditions that may come with retinitis pigmentosa is cystoid macular edema. If you look on the scans, I showed you the normal earlier, and I showed you the mountains. And if you look in the middle of the mountain, you see there's some black holes, and those are representative of fluid at the back of the eyes, and that's what we mean by cystoid macular edema. This is a more kind of severe form. It's just to highlight it and for ease of you to pick up. But these are treatable with medications, and it doesn't exclude you from clinical trials if the condition is treated and remains stable. So some of the other take-home messages from Sam and because I know within your community, these are some of the things that may apply and that it's important for you to take home, is like the most common genetic cause of deafness in Jewish and non-Jewish population is GJB2 or GJB6. So when you have a child or someone you know with the hearing loss, don't just think about Ushers. It might not be Ushers because the likelihood is the more common causes. And then just to let you know and remind you, and I'm sure Matt will tell you, the Jnetics current panel includes these three Usher's genes, the USH2A, PCDH15, and CRM, simply because of the recurrence rates. And also, just to let you know that there are free carrier screening service on the NHS, and anyone with a family history can be referred to local NHS clinical genetics department and get a free screening after discussion and look at the options. And for any confirmed carrier of any recessive gene, their partner can get screening if the carrier risk is greater than 1 in 70, for example, USH2A. And family planning interventions for any high-risk carrier couples, for example, if both partners have at least one mutation, are eligible for family planning. And you should take this approach, and we are all there, and everyone's there to help you and to support you. And just some resources, Gene.vision, and be part of research Moorfields. I checked all these, they do link and they do open, so they should be the correct. And then I would like, all those who are affected by the condition to be well supported. And there are plenty of support groups out there, Usher Kids, Cure Ushers, Deafblind UK. I'm sorry if I missed out any because I know there is so many, which is a good thing. And there's an upcoming Usher Kids Family Day Information Day in 10th of October, 10:10, and we'll be there. And hopefully there'll be more information for families who need the information, especially for the younger kids. Next. And just to say a special thanks to Professor Maria Musaji, for Sam Malka, and Professor Andrew Webster, and our team at Moorfields with Maria, Ngozi, our genetic counselors, our family support Jean, wonderful teacher, used to be a teacher, Tom, ophthalmologist, clinical fellows ourselves, and the nursing team, and all the wonderful technicians. Thank you so much.
Thank you so much, Randa. We really, really appreciate that. That was incredibly insightful. We've had a question in the chat from Dan just asking if it's possible for a copy of the PDF. Would you be okay with me distributing that afterwards?
Yeah, I'm sorry if I made any mistakes or any if there's any more recent updates. Yeah, I apologize
No,
in advance.
no,
Yes.
I'm sure you
No,
haven't.
I'm happy to, and because if it helps patients and if it helps anyone, please do.
I'm absolutely sure it will. And we've got a few questions
Yeah.
here. We've got one for you, and I've got one for Emma. We'll start with the one for you, just because you just finished. The question is, what age does the gene therapy need to be given? Other gene therapies need to be given at a very young age because damage can accumulate unless the therapy is given early. But with Usher syndrome, people might not be diagnosed until they're slightly older. So, at what age should these therapies be given, especially the new gene therapies?
Okay, so I'm talking about the one I'm recruiting at the moment. For example, Luna, the cutoff age at the moment is 8. And the reason why, and sometimes the reason why, as you just said, a lot of the patients don't develop symptoms until later. And so patients have a good reserve of the photoreceptor cells. And also, if you imagine, like at the younger age, patients will have to undergo general anesthetic in order to get the treatment. And at the moment, with intravitreal vertefersen, it has to be given every 6 months. So that would mean the children having to come for assessment and for injections every 6 months. Does that make sense? And
Yes.
so it's a balance. We feel, of course, ideally, we would like to give it before any damage occurs. That is that is what we're aiming for. But of course, it's an investigational drug, so we have to weigh risk versus benefit. If the patient has a very large reserve photoreceptors, and and they are still quite young and requires repeated anesthetic, we have to weigh but we always discuss with the patient and the parents and how they think. And a lot of the time they feel, oh, they want to wait till this has been through phase 2, phase 3. because they feel the child can maybe wait, just, for benefit of doubt, which we totally understand. So it's a matter of balancing risk and benefit, and we never decided alone, other than if there's a cutoff, unless they're below 8, we always discuss with the parents and the patient, and it's always an informed and together decision.
It makes a lot of sense. It seems like quite a difficult balance to strike, but yeah, it seems like everyone's doing the best they can to try work that out for their patients. I've got a question for Emma, which is that we've heard just now from Rand about the amazing work going into distributing new treatments for patients with Usher syndrome. As part of the of Deafblind UK and the Usher network in particular, what work does your organisation do to enable people to access to be aware of the resources and the care available in order to make sure people aren't kind of in the dark about the updates and the treatments that are becoming available?
Yes, so at Deafblind UK, we do send out our regular newsletters to keep people informed of the most up-to-date information that we have in terms of research and genetics. For example, we did create a sort of newsletter report following the conference in Holland last year. And Dr. Randa has talked about the Patient Information Day, which we had quite recently, which helps us to keep that up-to-date information out into the community. So we do promote a lot of that. We also do have a lot of family and friends that get in contact and want to find out more. So we always do arrange sessions either face-to-face or remotely to provide further information. If they really want to find out more, then of course we are here for signposting and referral on to find out further information directly from them themselves and see what fits them best, what suits them the most.
Fantastic. That seems like incredible work and very, very important. We've got a question from someone who's joined via the phone, so I can't see their name, but I'm going to unmute them. They've got their hand raised, and then you can ask the question.
Oh yes. Can you hear me?
Yes, we can all hear you.
Hello.
Yes.
My name is Mark Dample. I'm a long-term member of Deafblind UK and formerly at Sense. Yeah, the question is a couple of very simple questions. One is you mentioned about balance with Usher syndrome. I've been doing Tai Chi for many years, which is it's supposed to help with your posture and balance and circulation, and finding that Tai Chi could help us with Usher, because one of the worst things that could happen is you have a fall. So I was just wondering whether any evidence is provided in that area. And the other one is that could be very interested in any further research for people with advanced retinitis pigmentosa, because I do have Usher type 3A, but whether there would be a possibility to restore macular central vision to recognize somebody's face or to read very large print on a CCTV.
Those are two fantastic questions. I think maybe Randa's probably best place to answer them in terms of related to treatment.
Yeah, I think one, maybe I went over too fast, and I think there was one form of treatment we looked at called optogenetics. Did you hear that part? Or maybe I went too quickly?
Yes, it's quite possible that I had to take an urgent phone call during that particular year, so I wasn't aware of any further developments.
Okay, so currently there are research going on called optogenetics, and that is for exactly like is for advanced stages of retinitis pigmentosa, where the cells have degenerated, a lot of the cells have degenerated already. So that, like you said, the aim initially is some form of navigational, no, just like you said,
Yeah.
it might not be very detailed vision at this moment in time, but at least some navigational vision is what they're trying to aim at. And there are studies going on which are promising, but we don't have, with the full results available, and they're not always available in the UK.
Mhm.
And so, but if you were eligible and you would be provided with information or, opportunities should they arise. So please keep in touch, like make sure your update, like I said, be updated on your contacts and you're in the database, go for follow-up and make sure you're known, just be on the radar. Should there be anything available, then we would, if I was doing, if I'm, for example, when I'm of a trial, we are actively looking into the database for patients who are suitable, and we would contact you if we thought you would be eligible for something. Does that help?
Yes, it does actually. Yeah, yeah.
Yeah. So just do that. Make sure. Yeah. Where are you based?
London.
Okay, good. Good. You're very close, so no problem at all. But just make sure, like, if you're not in seeing any ophthalmologist, contact your GP, get referred, and just make sure you're on our radar. Is that
Radar,
okay?
yeah, that's the main thing. Yeah, got it. Yeah.
Thank you so much for that question. I'm sure it helps not just yourself, but a lot of people listening. Really appreciate it. That's all we've actually got time for tonight. I'd like to once again thank Emma and Randa so much for their amazing contributions. Everyone that signed up with their email will receive an email with a recording of tonight's lecture, and I'll also attach a link to. I'll also attach the slides that Randa provided. And brand new for this edition of the lecture is what we're calling the Lecture Extra, which is a short podcast interview I recorded with Emma a few weeks ago. A slightly more casual conversation, going into a bit more depth about her life and career with Usher Syndrome. So that will also be on our YouTube channel, which you'll find a link to both that and the recording in the next few days. That email, like I said, will also include a PDF. And stay tuned to your emails again for the next and upcoming editions of the Jnetics lecture series. Thank you so much for joining, everyone. I really appreciate it, and have an amazing evening.
Thank you very much.
Thank you so much, everybody. Good evening.
Thank you, Emma.